Hi, everyone. Thank you for joining. We'll start out in 1 second. I just want to make sure we get as many people as possible on before we start. You know, our CEO, Jennifer Kovich-Bordenick, whenever she runs these, she likes to ask where everybody's calling in from. And so I will do the same because I love that. It really gets everybody talking. I will start. I'm calling in from, I'm joining today from Arlington, Virginia. Elizabeth, where are you joining from?
Oh, I'm joining from Ann Arbor, Michigan.
Ooh, I talked to a bunch of people from Michigan today, 2 different meetings. It's great. Ooh, Cambridge, Rockville, Maryland, Portland, Maine. Is anybody from New Hampshire joining? I always have to ask because I grew up in New Hampshire. Lashell, where are you joining from?
Austin, Texas.
Anybody from, I think we already saw some Texas, more Texas guys. I don't know if you guys are watching the chat, but we have a bunch of them coming in. This is so exciting. And then what about you, Tannaz?
Ooh, a lot of Texas.
It sounds like we're neighbors, and I'm in Arlington as well.
Hi, just moved to Pentagon City. It's very windy. I didn't expect that. Yeah, all right. Oh, I'm getting distracted. All right, I guess we will get started. I saw that somebody works in New Hampshire and I will count it. So you're welcome. Thank you. All right, so thank you for joining again. We are the, well, I'm Emma Valinsky. I'm the manager of policy and programs for the executives for health innovation, EHI. We are today going to talk about health equity and public health. It is one of our modernization series that we've been putting on. This is actually the 4th one, and it's the last one of different topics, and we will be closing it together in a little bit with a report out of everything our groups have been doing. So Jen, can you just keep clicking? All right, so basically EHI, we are we're EHI, we're a small nonprofit, small but mighty nonprofit. We are a catalyst for healthcare transformation. We convene diverse leaders from all across the healthcare industry, and we work to find opportunities for collaborative innovation. Next slide. So for 2022, our focus areas have been virtual care, privacy and security, and modernizing public health and health equity. So we're actually focusing on 2 of these big areas today. I know our members have talked about this a lot, and so that's why I'm excited to talk about it today. Jen, can you keep going?
I am pressing it and it is not going.
All good. You got it.
There we go.
Perfect. All right. So this slide here is an example of all of our members. We love getting everybody involved. So if you are looking at these logos and you don't see your own logo, please feel free to put that in the Q&A or the chat and we can get in touch. If you do see your logo on here, remember that you are a member. If your organization's a member, you're a member, and we'd love to get you involved. We have so many awesome activities and you really can connect with all types of executives, like I was saying earlier. I highly recommend. Next slide. So as an example of some of these great activities coming up, we are hosting a webinar on May 17th, addressing workforce challenges in a post-COVID world. I feel like we hear about workforce challenges over and over, and I'm very grateful for Pro-Lucent Health for helping us talk about that. Next slide. Technology. All right. And so another webinar coming up, we have ensuring provided data isn't the source of surprises. And that is on May 19th at 1 p.m. If you guys want more information on this, if you'd like to register, you can just go to our website, ehidc.org. Jen will probably put that in the chat, and you can go and see all of those events, plus all the ones we have coming up.
Emma, I just have to give you some kudos because I never knew doing the slides was so hard.
Oh, exactly.
It
My job is
really
very
is
hard.
nerve-wracking.
Appreciate it. All right, next. All right. So I would say, you know, COVID has really shined a light on how outdated some pieces of our public health system is. And I say that everyone's like, yeah, Emma. So I'm very excited specifically to bring up the piece of health equity. I'm very excited about this because I feel like it's part of every single discussion we've been touching on, but this really will get to the heart of it. And so I'm very excited for our speakers today. So we have Dr. Elizabeth Cope. She's the Senior Director for Health Systems Improvement and Public Health and Population Health at AcademyHealth. We have Tannaz Rasouli, Senior Director of Public Policy and Strategic Outreach at the Association of American Medical Colleges, and Lashell Thomas, Senior Project Manager at Aetna CVS Health Medicaid. All right, so on that note, let's get started. I'm very excited. Elizabeth, would you like to take the stage?
Yes, thank you very much. It was fun to listen to that whole intro. You have lots of great energy. So hi, everyone. I think, well, it's not actually afternoon everywhere yet, is it? So I guess good afternoon and good morning, depending on where you are joining us from. It is a pleasure to be here today talking with all of you about such an important topic that's really near and dear to my heart. I would like to thank our hosts at EHI for their commitment to health equity as a key focus of this modernization series, but also of their work at large, and for including me among such a distinguished group of panelists. So I really appreciate this opportunity. And I know that I am also really eager to hear insights from my co-panelists on what we can and should be doing in public health to advance equity and action on social determinants of health data through the lenses of informatics and policy. So I'm Elizabeth Cope, and as mentioned, I'm a senior director at AcademyHealth, overseeing our program areas related to health systems improvements as well as public and population health. I want to just give a little bit of background on AcademyHealth. So we are a 501c3 nonprofit with the mission of improving health and health care for all by advancing evidence to inform policy and practice. So in other words, we are a research to policy and practice catalyst, primarily serving the fields of health services and policy research. And we actually we're really proud of the recent update to our mission statement where we added for all when talking about our goal of improving health and health care as a way to clearly signal our own deep commitment to advancing health equity and as a way for us to build in mechanisms of accountability when we assess our own performance against, how well we're serving our mission. So we consider ourselves of the field and for the field. So across our small but mighty organization of 50 employees, we offer a diverse array of programs to advance the field. And these range from convenings, fellowships, and professional development offerings to quality improvement collaboratives, technical assistance, and implementation science initiatives, where we really partner with the boots on the ground to accelerate translation of research findings into measurable improvements in care and outcomes. And these core competencies are a clear reflection of our 4 strategic goals, which include accelerating and amplifying the impact of the field, developing and sustaining a diverse workforce, deepening our relationships with those who use evidence to drive health improvement through robust engagement work, and harnessing innovation and technology to build and advance new evidence. I think the last thing I'll mention about us, although it's great fun for me to talk about us, as you can tell, is our recent organization around 3 cross-cutting strategic focus areas. And here, what we wanted to do was enhance our ability to make a difference and advance our mission by aligning our work around 3 core areas. And those include science innovation, so rethinking how we do research to ensure we're optimizing methods that prioritize rigor, relevance, and implementability. Diversity, equity, and inclusion, which focuses on infusing the principles of DEI throughout the composition, objectives, and outcomes of our field. And health systems improvement, which in our case is really focusing on building a stronger, more resilient learning health system that's designed to achieve the quintuple aim. So as an organization, we spend a lot of time thinking about what evidence generators and evidence users could and should be doing differently to advance equity, as well as what we could be doing in our role as a bridging organization and catalyst to improve, accelerate, and amplify that work. So that's a little bit about who we are. But now I want to switch gears because I know I was asked to talk a bit about the role of public health in advancing health equity. And I think to do this, we have to start by level setting on some concrete definitions. Because I find if we understand what all of these terms mean, it really becomes a natural conclusion that equity is a central focus of public health. So if we follow the World Health Organization in defining health as a state of overall well-being, so physical, mental, and social well-being, rather than just the absence of disease, then we must necessarily see health as a precondition for human flourishing. Well-being enables people to meet their aspirations, fulfill social roles, engage in productive and beneficial actions, not only for themselves, but for their fellow citizens and future generations. So that's I think how we should be thinking about health. And then what is health inequity? And so here, we can also be informed by WHO in thinking about health inequities as systematic differences in health status or the distribution of health resources that arise from the social conditions in which people are born, grow, live, work, and age. In other words, the life circumstances that are shaped by the distribution of money, power, and resources. And evidence on the existence of health inequities is overwhelming. If we look just in the US, life expectancy varies substantially depending on where you live, down to the zip code level. Infants born to Black women have 2 to 3 times the infant mortality rate of non-Hispanic white infants. Bias and discrimination in the health system has been associated with delays in diagnosis and treatment. And so that's just to name a few examples for us. So when we think about improving health, we should be putting equal weight on achieving improvements in overall health, as well as the distribution of health as a way to measure health systems performance. So whose job is it to address this? We certainly see principles of equity embedded throughout definitions of health and public health, from WHO to CDC to the 10 essential public health services and beyond. And we can think about public health as what we as a society do collectively to assure the conditions in which people can be healthy. And under this definition, we see that public health is a multidisciplinary enterprise with a knowledge base grounded in natural, biomedical, and social sciences, and that activities to enhance healthy outcomes operate at the level of individual behavior and at the level of policies and practices affecting entire communities. And so it's really this collective dimension of public health that's what sets it apart from clinical medicine, and also what makes it a precondition of a well-functioning society. And so there's a robust empirical and philosophical literature that links public health to principles such as justice, beneficence, and dignity, which are the foundations of a society that assumes collective responsibility for all of its members. So in this vein, I think we can link public health to human rights, that its activities can and should extend to political, economic, social, and cultural aspects of human existence. So while I think it's going to take adopting a focus on equity throughout all components of the health improvement landscape, I think public health is, by its very essence, best positioned to lead that charge, and indeed has the responsibility to do so. So if we center ourselves on the core functions of public health, those being assessment, assurance, and policy development, I would say the role of public health in advancing health equity must include, at minimum, documenting health inequalities, identifying inequities, advocating for action, and then ensuring that action is guided by both evidence and ethics. So if we think about that role, we can see the foundational importance of a strong data collection and analytics infrastructure. Data are needed to demonstrate the presence of a problem, guide analysis of root causes and intervention opportunities, and then evaluate the relative success or failure of any action taken. And if we're going to be doing this to advance health equity, it's going to mean capturing data on the social determinants at multiple levels and knowing how to turn those data into actionable insights. So with that, I'm going to conclude my remarks and certainly look forward to hearing from my colleagues about how we can ensure public health can build and sustain its social determinants data infrastructure, and how public health initiatives are using data to drive improvement in equity. Thanks again for the opportunity to join in this discussion, and I look forward to the conversation to follow.
Thank you so much, Dr. Cope. Lashell, would you like to take over now?
Good afternoon, coming here from Austin, Texas. So I'm going to piggyback off of what Dr. Cope said. So I'm going to look at it from two different perspectives. So just starting off by just giving a little bit of my professional background. I have 15 years of professional experience working in analytics and portfolio management and process improvement across the healthcare sector and across the public health sector as well. I have worked in the hospital setting. I have worked in the ambulatory care setting. I have pivoted over to management consultant and even had the opportunity to work in a state agency around the Medicaid and CHIP services. And then coming back on the CVS Health a second time and working for Aetna as a health plan. I am a senior project manager. I am specifically under our medical management arm. I support our Region 5 in care management, care case management, however you want to phrase it. I'm responsible for supporting our strategic and operational initiatives across Maryland, Florida, and Kansas, despite the fact that I don't live in those states. And we tend to take an approach in Aetna where we don't just focus on the clinical care that our members get, but we think about them from the psychosocial aspect. And so we very much look at the social needs of the member as well. So I know that Aetna has a very strong focus on health equity and really being in our local communities as well. I'm also going to be talking from the perspective of being a doctoral candidate. So currently I'm a doctoral candidate in the dissertation phase at the University of Illinois, Chicago in the DRPH program in public health leadership. That felt like a mouthful. I'm also pursuing a master's certification in public health informatics. I don't know if we defined informatics, and I know that many people define informatics very differently. So my plain definition of informatics is the effective and efficient use of information and information systems in order to help inform public health action in the hopes that we address those three core functions of assessment, assurance, and policy development. So I was actually asked to talk a little bit about my upcoming dissertation research. So my proposed dissertation research really looks at the local health department perspective in all of this and really trying to understand how they are able to use informatics to address health equity in performing their core functions. So if we back up a little bit, there's been a lot of heavy focus on health equity over the past decades. We see it in Healthy People 2020, Healthy People 2030. We see the Office of Minority Health has developed a health equity framework around how to operationalize health equity within the health department. We have health in all policies. And of course, we have Public Health 3.0, right? And Public Health 3.0 really looks at the local health department leaders to be able to be this chief health strategists to really facilitate these conversations with other sectors to help address social determinants of health and to really look at how we address health equities, right? And the basis of all this conversation around health equity is really around data, right? It's around having timely data, granular data. And as Dr. Cope said, not really looking at data from a state perspective or a county perspective, but we really need data at a sub-county perspective at a zip code level to be able to drive action and to inform decision-making about where to allocate resources in our communities. So public health 3.0 era, I would still say we're in public health 2.0, and we're driving toward public health 3.0, where we are the chief health strategist. And so when we come back to that question about who is driving health equity, I really don't think it lies with just one person. It really lies with everyone. But if you think about the public health 3.0, it really kind of envisions that the local health department will be kind of the leader, the facilitator, that's chief health strategist in driving those partnerships with other sectors. And I do think we have a long way to go from that. I think that's a very good vision for public health. But I think currently, and this is what what I've gathered in my research so far, is that we are very far away from that desired state of having those partnerships to talk about health equity and to address it. If you think about local health departments, even our level of implementing informatics has varied across the country. So NACHO is the National Association of County and City Officials. They do a profile study maybe once every 2 to 3 years. And so it looks at the demographics and it looks at the activities in local health departments and it looks at funding and it looks at the leadership. But what they included over the past few surveys was a piece on informatics. And they look at 5 different systems and how they are adopted and how they're implemented across the country. Sorry, NACHO. NACHO is a profile study that's done on the local health department. It's a broad survey that's given out to the 2,500 plus health departments we have in the country. And it really assessed the lay of the land, the current status of health department operations. And so there's a module on informatics. And what you will see is that they'll look at 5 different information, NACHO, NACCHO. So they look at 5 different systems, immunization registries. They look at electronic disease reporting, electronic laboratory reporting, electronic health records, and participation in health information exchanges, right? And what we see is that there's great variation based on the size of the health department. So health departments are usually separated into, based on the population that they serve, small, medium, and large. And then they're seeing a lot of variations in what systems are being adopted and which ones don't have a high adoption rate. And so things that are traditional public health, like immunization registries and electronic disease reporting, and even electronic laboratory reporting, the adoption has been pretty strong over the past number of decades. And what we're seeing is that the electronic health record adoption and the participation in health information exchanges is a lot lower. It's not being adopted as we would hope after all these years of talking about those systems. So I believe that, yes, health equity is important. Using data to be able to have timely, granular data is important, but I think in the public health sector, we just have strong variation across those systems, right? And so with my research, I really want to understand, at the same time, even though there's variation, there are health departments that are able to leverage the limited funding, because if we think about it, over the past how many years, we have spent more money on healthcare and less money on the public sector, less investment in the public health infrastructure. We have a reduction of the workforce in the public health sector. We are expanding the responsibility of the health department. We're going from an emphasis on infectious disease to wanting to understand more about chronic disease reporting and monitoring, to having these crises that we're dealing with, Ebola, Zika, the pandemic that we have been dealing with for the last couple of years, COVID-19, we still don't have additional funding for the health departments. We still are dealing with limited staff. We're dealing with staff that is kind of trying to do many things at one time. They're trying to do their day-to-day operations, and they're still in crisis mode, trying to handle everything that came with COVID-19. And so despite all of those things, there are some health departments that have been able to use informatics in order to support health equity. And so with my study, I'm hoping to look at how they were able to develop that internal capacity in terms of their workforce, in terms of how to design their systems. How did they develop a process to being able to support it from an operational perspective? How did they know they were ready? And then what does that initial phase of capacity planning look like? So I'm hoping to leverage that research to be able to gain some best practices, because yes, we're still challenged around funding, and yes, we're still challenged around the workforce and having enough resources, but we still need to know how we develop that internally. So I may have gone over a little bit of my time, so I will stop right there.
No, that was great. Before we move on, I want to remind everybody, start asking your questions. We're excited to hear from you. That's the best part of these webinars, is that you get to ask the questions that you've been dying to ask to some experts. So yeah, let's get started. Tannaz, it's you.
Great. Thank you so much for the invitation and for the opportunity to join the discussion today. And the best part of going last is I get to say yes, everything that they said. So hopefully I won't replicate too much of what my co-panelists said, and will just complement their comments. So as was mentioned earlier, I work in government relations for the Association of American Medical Colleges, or AAMC, which represents all 155 MD granting medical schools in the country. Our name is a little bit of a misnomer, though, in that in addition to the medical schools, we also represent about 400 major teaching hospitals and health systems, as well as approximately 70 professional and academic societies, representing essentially the faculty at all of those institutions. Our members represent only about 5% of all the hospitals, but they have a disproportionate impact on the care that's delivered all across the country. So they account for about a quarter of all inpatient care. The vast majority of highly specialized or critical standby services are concentrated at academic medical centers, from level 1 trauma centers to comprehensive cancer centers or stroke centers or transplant services and other services such as those. Compared to other facilities, the patients that our members are treating tend to be more diverse, more underserved, tend to be sicker, and they tend to require a little bit more complex care. In addition to their clinical work, our members also are the predominant sites of medical research. So they conduct more than half of the research that is supported by the National Institutes of Health all around the country. And as you may have guessed from our name, they are also the primary training grounds for the next generation of physicians, but also a whole range of other health professionals. And they also are anchor institutions within their communities. They often serve as the largest employer in either the region or the state, and deliver a pretty substantial economic return to their communities. So when we talk about our members' missions, we describe essentially 4 parts, 4 components to those missions, namely research, education, clinical care, and really trying to build meaningful community collaborations to improve health equity, both locally within their own communities, but also I think most of our members really think of themselves as trying to improve these areas nationally as well. So given all of those intersecting missions, our members have really been engaged in just about every dimension of the nation's response to really just about any health threat that the country faces. So using COVID specifically as an example, they were immediately leveraging their research mission to develop tests and actually deploy those tests. They were treating patients and developing new clinical care protocols as we learned more about the virus, and sharing those protocols more broadly to other providers across the community. They're advancing the research that led to the vaccines and the therapeutics that we now have in place. And in many cases, they serve as essentially extensions of their state and local health departments, whether it's administering large-scale vaccination clinics or offering data modeling and analytic support, developing and helping to deploy contact tracing processes and training protocols, extending outreach to marginalized and under-resourced populations. You really saw academic medical centers trying to fill voids where they existed and trying to augment the efforts of their public health partners. Based on those experiences, the AAMC has developed a few different reports. We published one in September, trying to capture and share some of the lessons learned from that COVID experience. We also sent 36 pages worth of very detailed recommendations to Congress about how to sort of rebuild our preparedness infrastructure last summer. So I won't go chapter and verse into all that we're recommending. But I wanted to just pull out a few themes that I think might be particularly relevant to this discussion. So first, on the point of health equity overall, I think, as you all know, COVID was a stark example of the inequities that historically marginalized populations continue to face. But we all know those inequities didn't just manifest overnight and didn't, result just as a result of this specific pandemic. They are rooted in systemic issues and structures. And we know that it's only about 20% of a person's health that is attributable to medical factors. The other 80% is shaped by social determinants. So we feel very strongly that we really need to be tackling those issues directly, but also applying a health equity framework to every element of our planning. And so in all of our recommendations, I think we've tried to really weave an equity mindset. So for example, we have endorsed legislation that would provide funding to state, local, tribal governments, essentially to support planning grants for programs to address non-medical factors of health. So that's a very direct, targeted intervention intended to help improve and make progress around social determinants of health. But we know it's not sufficient just to stop there. We need to ensure that we're advancing policies that are actually engaging communities in a meaningful way, and that we're earning the trust of the communities that we're engaging. So the AAMC recently launched a new Center for Health Justice, and the mission of this new center is to look broadly beyond medical care at all the different factors that influence people's health and how we can actually affect change. And one of the very first products that the center released was a set of 10 principles of trustworthiness, essentially intended to guide clinicians, public health professionals, policymakers, and others in trying to demonstrate that they are worthy of trust. So it's one thing to expect communities to trust what we're doing and what we're expecting. It's another thing to actually take the steps necessary to earn that trust. Second, if there was any doubt, I think that the current pandemic really illustrated just how outdated our public health data systems are and the consequences of those limitations. We feel strongly that we need to be investing in modernizing those systems at every level, local, state, federal, but also in developing a framework that identifies in advance what sort of essential data elements are needed at different levels of a response, how feasible it is to actually collect that data, how comparable and standardized and interoperable that information is, not just across jurisdictions, although certainly across jurisdictions, but also across different settings. So from the hospital to the health department and vice versa, for example. I think that notion of trustworthiness really comes into play again here in this area. And we've emphasized that we really need a commitment to transparency as part of that. I think that's especially critical as we think about the type of data that's needed to tackle health equity in a meaningful way. So my colleagues who are really steeped in these issues tell me that, for example, looking at social determinants data using 5-digit zip codes is a good start, but it's not necessarily sufficient because it might not be specific enough in densely populated communities that are likely to be most affected by infectious disease. You really need to look at census blocks or locally defined neighborhoods. And we need to be capturing race and ethnicity information, yes, but we also need to be thinking about other social needs and vulnerability information in a way that's not stigmatizing and in a way that is cognizant of the potentially very personal and sensitive nature of some of this information. If we're going to be successful in that endeavor, it again needs to be a process and a framework that is established in collaboration with and with broad input from the community itself. The final point that I'll just mention is that, I think we really need to think about opportunities to break down silos where they exist. I don't think the general public really distinguishes between the public health system and the healthcare system. Mm-hmm. I think we all know that in reality, in many communities, those two entities are operating on parallel tracks. And we are really missing opportunities to leverage each other's strengths to mount the most efficient and most effective response possible to, again, just about all of our public health threats. So, given their missions, I think we're biased, but we think academic medical centers are in a position to really be that bridge between public health and healthcare delivery. And where that's happening organically, I think there are examples of where it's working really, really well. So the more that we can think about opportunities to enhance those sorts of collaborations and synergies and partnerships, either formally or informally, I think the more progress that we're likely to make in really tackling some of these pervasive public health challenges. So with that, I will stop babbling and turn it back to you, Emma.
All right, awesome. Thank you. So before I start asking my questions, I want to remind everybody that you can ask your questions and we will get to those in a few minutes. So feel free to send them all in. And I'm going to start with, I guess, let's still talk about COVID. What? Okay, we all know that COVID-19 highlighted a number of inequities in our current system. Do you feel like it made a meaningful difference in how federal, state, and local public health agencies are approaching public health?
And Emma, I can step in if that's okay.
Absolutely.
Okay. So if anything, when I think about COVID-19, I think we can agree that as a nation, I don't think we handled it very well, right? I just don't, right? And if anything, I think COVID-19 would have been a great opportunity to highlight what public health does, right? We said, many decades ago that public health has a responsibility of supporting those kind of things, assessment, insurance, and policy development, right? That was a great test of assessment and insurance for sure, right? But COVID-19, I think, was a blessing and a curse, right? Because I think COVID-19 really highlighted what was wrong with the public health system in the first place, right? So the first thing I really saw was that we had this battle between the government and the public health agency, right? Here's the government trying to say what to do to handle this pandemic. Here's the CDC saying its guidance on what we should do, and the guidance changed from day to day. We, instead of giving authority to our state health departments and to our local health departments, we asked our governors what to do. How long should we quarantine? Who should wear a mask? Who shouldn't wear a mask? Should we go into our place of business? Should we work from home, right? And we gave that to the governor when it should have been the domain of the public health agency, right? It highlighted that we have a lot of challenges within the health department. We have antiquated systems. You have health departments that are still doing manual processes to get cases reported, right? They still have a shortage of workforce, right? So when you think about contact tracing, they didn't even have enough staff to even support that effort, right? They had to seek temporary staff and train temporary staff to help support those efforts, or they had to divide up their staff into supporting those efforts, right? You know, we talked about race and ethnicity data, right? We still don't have a good, clean way of getting race and ethnicity data for public health purposes, right? A lot of the data that comes over doesn't have that information, but if we did have that information, we would have been able to say, hey, and we would have been able to know the prevalence of COVID-19. We would have been able to know new COVID-19 incident rates. We would have known what communities were getting hit harder. And again, we don't have that granular data. So a lot of public health is at the local level. It's at the zip code level, right? And if we don't have information at the zip code level, we really didn't know how to allocate our resources effectively with COVID-19, right? I think if anything, it really did highlight kind of the fragmented nature of public health instead of giving the opportunity that it could have given to really show what public health does, right? But I do think, if anything, I hope it's sort of a wake-up call to like officials, elected officials, to really understand that, you know, we should have had what we needed before the crisis hit, right? We should have been invested in public health way before COVID-19. And I really hope that once we get through this period, whenever we get through this period, then the next time a crisis comes, we take public health a little bit more seriously, right? And we don't take funds away from public health. Even for the healthcare sector where I sit in, right? We tend to take more money over for the healthcare sector. We tend to divert it to every other place but public health. And I think COVID-19 really highlighted kind of a missed opportunity to be prepared. So that's my thoughts on it.
No, that is excellent. Thank you so much. Do you guys have anything else to add?
Yeah, I will echo a lot of what Ms. Thomas highlighted, in the sense that, you know, I think maybe it's raised awareness about some of the challenges, but a lot of the challenges didn't manifest overnight. It's, you know, long-standing underfunding and, you know, lack of attention to how to build the infrastructure that's needed to really tackle these challenges. And you would think after 2+ years and all of the grief that we've been through and experienced over the last 2 years, our federal government has literally spent $6 trillion as a result of this pandemic. And yet the vast majority of that has gone to recovery. I mean, we have a whack-a-mole approach to these sorts of crises. And as much as I would like to think, and as much as we will continue to push policymakers to really think about what are the systemic changes and the infrastructure changes that need to happen, how can we rebuild this infrastructure? You know, I worry that we're entering this phase of COVID fatigue and everybody's just sort of ready to move on to the next chapter. So I think it's going to take, you know, a lot of different sectors, collective voice across the community to continue to put pressure on policymakers to ensure that, you know, our public health departments and, you know, professionals across the country have the infrastructure and the resources they need to actually implement some of the changes that need to happen to tackle these issues.
Great.
I think so. There were a lot of excellent points that have already been made. So I'm not going to talk for long. I think the one thing I wanted to just add was to raise the issue around the politicization of public health, and sort of as the country has become more and more polarized, they have also made science political as well, and that has really had an impact on the ability of, I think, the message that comes out from evidence, from science, to have the impact that it needs to have to improve the lives of everybody, because we've turned it into a political issue. And so I wanted to raise that as sort of another challenge that we saw, and one that I don't think our experience with COVID is helping at this point. It's not like, oh, well, we experienced that, it was terrible, so like, let's all come together and fix it. I think this is going to be a challenge that we continue to face and need to sort of reckon with, and figure out how to pull. And I don't think this is also unique to COVID. We have seen the politicization of science elsewhere as well. We just got to experience it in a bad way very recently. But it highlights for us the need to figure out how we pull public health out of politics. I know I've seen comments coming through around how do we get funding for public health and things like that out of this 1, 3, 5 year cycle, which really, you can think about as also moving that into what are term limits and those kinds of things. And the reality is we've got to figure out a way to tease those kinds of things apart. So I just raised that as well.
Oh, perfect. Thank you. Thank you so much for those. I was going to ask you guys another question, but we actually have quite a few coming in from the audience, so I will jump over to theirs. We have one. What is your specific advice to executives and leaders as far as rebalancing power structures to be able to uplift the community voices? And perhaps you've heard some strategies or best practices on that.
So I can start, and I don't have the specifics to share, but I would refer you all to the website. I'll put the link in the chat to our Center for Health Justice, which is, again, structured specifically to try and create those sorts of opportunities. So we've built a multi-sector coalition that is serving as an advisory board to the work that center is doing. That's the venue, again, with those principles of trustworthiness came out of. And so that might be a starting point in terms of how to engage the community in a meaningful way. I think, what my colleagues have shared with me is that it really needs to be bi-directional. Too often, I think there's, an assumption in terms of, who is leading and what the knowledge base is and what the expectations are in terms of the purpose for those types of efforts. And you really need to commit to thinking about it as a two-way street and really being broadly focused in how you're structuring those types of efforts. So I'll include the links to some of those resources in the chat in case that's helpful.
Awesome. Thank you. Also, for everyone listening, all of the resources that we've been talking about, everything that's in the chat, I'll make sure to download and send out to everyone. So feel free, if you missed something, I'll make sure to get it over to you guys. Did you guys want to touch on that, or would you like me to ask another question?
Well, I would just touch on that a little bit. I think if you're going to rebalance power structures, it means you have to give power to other folks. So I do think that governance is a good way to do that, and thinking about how you can bring community members and elevate community voices in your own governance, and make sure that those perspectives then are being represented not in a tokenistic way, to be able to drive decisions that get made. I think also certainly bringing folks on, not just in the governance of say the organization as a whole, but if there's going to be a particular initiative that's community-based initiative, then making sure that that's being governed by members of the community, so that the folks that are being impacted by the initiative have a voice in how that initiative is designed, executed, and evaluated. I think that's going to be key.
Excellent. Lashell, did you want to touch on that?
I don't know, I think most of what I would think has been already said, but I will say that, I am a candidate in the DRPH program. And one of the differences between the DRPH and the traditional PhD is that we tend to think about our research as being pragmatic. And so with pragmatism, we believe that we are looking at real world problems that are going to drive, policy change and system change and environment change, right? And so a lot of the way we look at research is how do we look at the voice of the community, the participants, right? And how is this problem impacting them, and how is it impacting the broader public health system? And so I do agree that any research at least should think about the voice of the community that's being impacted, right? And they should be a voice in that research as well. It should be a two-way dialogue. And one thing we do say, and I think we tend to think that this is a very technical solution. We just have better data systems, or we add funding, or we get more people. But we say a lot in the DRPH world that this is an adaptive challenge, and it's multifaceted challenge. And there's a lot of different things at stake. We have, this political arena, we have this funding, and we have to build all of these partnerships, and public health tends to be very siloed to begin with, right? And so we even have to change the perspective of the health department. The health department traditionally deals with infectious disease control and communicable diseases. Even thinking about stuff like informatics, public health isn't very thought of as being very innovative, right? We are reactive, right? Thinking about looking at chronic disease management from a health equity standpoint, thinking about more than when a person's born and when a person dies. That's a different perspective of public health, right? And so it's more of an adaptive challenge at the end of the day than just a one-size-fit-all solution, I think, And that does involve multiple voices around the table, including the folks in the community.
Thanks. Thank you. So my next question is, I understand the question I'm going to ask probably would take up a whole other webinar, but I just wanted to put it out there because I couldn't not ask. Many communities, for people of color and Black communities, have fraught relationships with many of our institutions. They would like you to talk to how can we build trust within these communities so that they can feel safe with sharing their demographics, race, identities with the institutions. Yeah, everyone's like,
That's a tough one. It's a tough one.
I can ask I don't want to put you guys on the spot.
I think it takes work, and it takes an explicit focus and a deliberate effort, and it takes work over time, and you have to demonstrate that you're worthy of earning that trust, right? I mean, it takes specific steps to ensure that you're worthy of earning that trust. You can't just expect trust to be inherent. And yeah, I think it is a tough one. I mean, I think it takes time and effort, and it takes, I think Dr. Cope said, it can't be tokenism. It has to be, true commitment to collaboration and to understanding and to partnership and to building that trust.
Yeah, so, and I'm actually seeing some fantastic responses come in through the chat as well. I would echo the comment that, this is not something that happens overnight. I mean, it's one of those things where it can take years to build it, and it takes a second to lose it. But certainly, making sure that the communities that are affected are involved in, the design, the execution, the analysis, and the report back of whatever it is you're doing with those data is going to be critical. And making sure that you are transparent about what it is you're doing, how it's going to be used, and that you also are accountable. There are mechanisms of accountability built in, and for those communities to also hold you accountable. So there needs to be not just sort of self-accountability or sort of what we see, I think, in sometimes in some research projects where it's like, if they're like, there's no mechanism for, say, a community to hold the researcher accountable. You need to be able to build that in and make it possible. And then I think also just effective communication throughout. I think, you know, those are some key areas where I would focus on. I think there's some others as well, but a lot of that is it's about relationship building. It's about transparency. It's about accountability and inclusion of everybody sort of in the process throughout.
Awesome.
I don't have a whole ton to say on it, but I think as a woman of color, a Black woman, the way I would think about it is that it's hard to talk about trust when we are still in the thick of it, right? So a lot of how equity kind of stems to, like you said, social justice, right? And social justice has its root in systematic racism, especially in Black and brown communities, right? And we could say that was the past, and that was many, many years ago, and we're not dealing with systematic racism now, and it doesn't kind of perpetuate its way down into our health status and into our communities, but it's still happening. And so part of it is that even though we're having a lot of conversations around health equity, it's still a dicey topic in many places, right? People like to talk about health equity, but no one's gonna ever own up to maybe having done an act of racism, right? And so if we're willing to be open to saying, hey, I have some biases and I have some anti-racism behaviors, right? I mean, some racist behaviors, right? I think being able to own that, you know, that still happens today. It's not something that is in the past, and it's something we're going to be dealing with for a really long time, right? So really being able to be open about it is a step, right? You can't talk about health equity if you don't talk about social justice, and you can't talk about social justice if you don't talk about embedded systematic racism. And it's been many, 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 many decades of that. So I don't think it's going to change overnight.
Yeah, I appreciate you guys answering that question for us. So we only have a few minutes left, and my favorite question to ask at the end is, if everybody from this webinar walked away with only one single point, what do you think that point should be?
Just one point.
You can do two.
I guess my point would be, don't give up. I mean, I don't know. I feel like it's frustrating. I think it can be frustrating. And I don't know about any of you guys, but, you know, I feel demoralized after the last 2 years of what we've experienced. You know, what should have been something that is a wake up call, and that, you know, should have brought us together as a country, and that, you know, should have really been a rallying cry for us, has turned into something very political, and, you know, everybody's tired and ready to move on. But, you know, I think it's important for us to continue having these conversations and to continue taking steps forward. And so I guess that would be my one takeaway.
I can jump in. I'm happy to jump in. I think for me, it's especially when I think about public health and health equity, I would want us to be working harder to make sure that what we know translates into what we do. And I think there's a lot that we know, or there's a lot in terms of how we conceptualize public health, where we focus on, you know, the importance of policies, structures, systems, and the role that they play in health outcomes, in addition to, you know, individual choice, access, individual behaviors, those kinds of things. But I think when it comes to the work that we actually do, there's a bit of a dissonance there, and that has generated some slow progress to innovate and intervene at those higher levels of the social ecological model, which ultimately translates into failing to advance health equity. And I think we see that actually in the comments. I was very struck by that comment, the 1, 3, 5 year comment. But just our kind of focus on individual level behaviors, randomized controlled trials, the expectation that funders have about having results in short periods of time, those kinds of things, they don't align with what we know actually drives disparities, inequities, and poor health outcomes. And we need to move toward a stronger connection between what we know drives those things and how we do the work to address them.
Thanks. Shell, you got us at the end.
Okay, just a couple thoughts. And I said this one yesterday in a project call, and it's a phrase that we use a lot in the DRPH program, and we say to embrace the fuzzy, right? And as in my line of work, I always think that there is a solution, right? And everything is so black and white. And in the DRPH, we have learned that with problems, you have to embrace the fuzzy, right? There is no black and white solution to what we're trying to do here around health equity or around modernizing our public health data infrastructure to be able to solve, to be able to address health equity. But I also think that there needs to be a stronger top-down and bottom-up approach to how we address public health data and improving our public health data infrastructure. And, you know, I work in Medicaid. There are 50 flavors of Medicaid in this country, right? If you've seen one state Medicaid program, you've seen one state Medicaid program, right? And that's the same with our public health system. We have so much variation across the states in how we do public health and how we can share data and data privacy laws and data use agreements. We have so much variation in how we're dealing with data. And so we really need a stronger, more standard approach for top down and bottom up as well. So
Awesome.
I think it's a great conversation. I'm very passionate about public health data. I'm very much a data geek. And so I'm happy to have had the opportunity to be here today.
Thank you so much for you all coming and hanging out with us today. The conversation in the chat box, amazing. Thank you all.
I agree.
As a reminder, you'll have the recording will be on our website, and all the resources that you need will be sent out. Anyway, thank you so much. And we will see all of you later.
Have a great afternoon, everyone.